ايش كتبت؟ Hi, Ramesh. How are you?
Hello, good evening. Hello, you can hear me?
Yes, I can. Nikolay, where is Nikolay? I can hear you very well, Ramesh. How's everything?
Very good, very good. Thank you.
Okay, let's see if we can unmute Nikolai. I don't know what's happening here. Actually, for whatever reason, I was waiting for some time to be joined. I don't know what happened there. Yes, Nikolai, you're unmuted. You're all right?
Yes.
Hi, Nikolai. Good to see you. Welcome.
Hi, everybody. Pleasure being with you guys. Hello, hi.
Let's see if...
I think we have a few more minutes.
Yeah, we have a few more minutes to go.
Hello, how are you?
Hey, look who's here. My friend has all of a sudden gone young. You look so young, man. What happened?
Good morning, how are you?
Good afternoon. Everything is fine here. Okay, so I think what we are doing just now is, Victor, we had 5 MCQs from you, and one of my residents made 15 MCQs. So we're going to show those MCQs to our friends first, our participants. So they're going to solve those multiple choice questions first. We'll give them 10 minutes. In the meantime, we'll chat. And then we'll start our talk. And once our talks are over, at the end, we're going to repeat those multiple choice questions and see if you have taught them any good. And if you haven't, then then you have to pay for the whole 2 hours of Zoom. So is Mehak, are you there? Yusuf, are you there? Who's sorting everything out? I'm just waiting to see who's doing this. Actually, my secretary, Imad, he had some issues. His sister and brother-in-law and 2 kids died in a plane crash 5 days ago. So he's not with us. So we have somebody else helping. Who's hosting here? Is Mehak, is that you? Or Yusuf? Let me see what's happened. So let me unmute this person. Mehak, are you there? Yusuf? Who's going to be sharing these multiple choice questions? We're just waiting. So we don't know who the host is to start with. One second.
Somebody's writing. I'm here, sir, in a minute. I don't know who is
this.
That.
Okay, whoever it is, I think it's probably my other secretary. And she is, for whatever reason, didn't want to talk. No worries. So we have multiple choice questions. So guys, if you are people who have connected up to now, please, I would request that you, have you given them the link? Can we please give them the link to start with so that they can go on the link? Saleha, is that you? Saleha, you have to give them the link if you are there. And you have to speak up. Okay, we have the link. So can people go on this link and please fill solve these multiple choice questions? Let me just invite people in. Is Rocky, is he in here? Is Rocky already in? Let me just check. So guys, whoever have come in, Nicola, you may solve this multiple choice questions as well and see what you get. I wouldn't ask Nicola or Ramesh to solve, Victor and Ramesh to solve it because they are the speakers. So Nicola, you got your case done early?
Yes, hold on. It was a busy day for me this morning. I was in a panel for an interview, then I went and I operated. Now I'm with you, so it's a crazy day. But everything is as scheduled, so it goes well.
Here it's not crazy, here it's fun.
Yes, here is fun, but so far it was crazy. Sorry, I expressed myself improperly.
Okay. Let me just. So let's get Daniel, who's joined us as a moderator today. Daniel, can you please, I'm just unmuting you, and what you could do is you could get your video going, please. Brilliant.
Hello.
Hi, Daniel, how are you?
Good, how are things?
Not too bad. So Daniel is our friend. He's from George Washington University, and he will be moderating along with Nicolai today.
Exactly.
Can you, sorry, Daniel, can you introduce yourself since majority of the people don't know you here?
Sure. I'm a dual trained neurosurgeon. I'm here in Washington, D.C. I did residency at Georgetown and then at a Cerebral open and endovascular fellowship in Philadelphia. Nice to meet everyone.
Brilliant. Nicolai, you're going to introduce yourself. I don't have to introduce you. Can you introduce yourself, please? And then we'll start. Have you given them enough time to fill? Yeah.
Okay. Hi, everybody. Pleasure being with you today. And as usual, we are going to see amazing webinar today. I am honored to moderate. My name is Nicolai Peth. I'm a dominant consultant neurosurgeon in Royal Victoria Hospital, Belfast. That's Northern Ireland, UK, still.
Shall we give them 5 minutes more, Nicolai, to fill the multiple choice questions?
Yeah, we can give them that. Yes. Don't pressurize the young people.
Okay,
they have to have fun.
No worries. So please, guys, you haven't been sent the multiple choice questions, but these multiple choice questions are available on the form that you are filling. So please go on the form and fill them quickly because we need to get on with it. So in the next 5 minutes, we'll start. So we don't want you to be cheating afterwards. You have to fill that, and then at the end, you have to fill it again. So Daniel, Rocky, what kind of work do you do in George Washington? Do you doing vascular stuff or are you doing just general skull base?
It's the practice that we do is we do a little bit of everything, whatever comes in call. But I'm fellowship trained in vascular and endovascular. So like my last case was percutaneous screws for a burst fracture, and then the case before that was a COVID stroke.
Right, let me see if we are done with. So people are saying they can't see MCQs at the end of the form. Okay, if we can't see, I think we're going to start and then we can do them at the end only. Okay, thank you. I think let's just, Nikolay and Rocky, you can start. You can introduce our guest here.
Okay, shall I start?
Yes, I think so. I think there is, and Victor has to share his slides. So carry on.
Okay, I'll start with Victor. So it's great pleasure to introduce to all of you Victor. So I was thinking how to introduce Victor, and I was thinking maybe we can say that if we have to write an article in Wikipedia, what is anatomy artist, we have to put Victor's photo there. Amazing. Victor is always presenting to us amazing models, amazing anatomy research, and I can't wait to see now what he has prepared for us today. Victor, your turn. Victor, can you hear us?
I think it's probably muted. Let me see.
For all the other people that are watching, Dr. Perez has many videos out there on anatomy. And if you want to know more about, today we're focusing on blood vessels, but yeah, he's got beautiful other lectures that are available on YouTube.
But where did Victor disappear on us? 1 second.
You're still muted, Dr. Perez.
Nikolay, can you see Victor where he is? So I can
No, I don't.
Okay, yeah, right. Okay, I'm okay. Okay.
All right, Victor.
Do you hear me?
Yes.
Okay. Let me show my screen. Okay, this is. Can you see it?
Yes.
Yes. Okay. Okay. Thank you very much for this opportunity to show this work. I feel very happy to be here with you and also with residents from Pakistan and some other countries. We are going to present the brain arteries. Okay. What I am doing is to inject fresh brains, with latex, colored latex in color blue veins and in color red the arteries. This is very useful because you can identify very small branches and also the large arteries in the brain. Here we are watching the M4 segment of middle cerebral artery, also known as cortical segment of middle cerebral artery. This is really useful and nice because we can identify very, very small arteries. As you know, brain requires a rich blood supply to sustain its activity. Irreversible brain damage, brain death, results if the blood supply to the brain is interrupted for more than a few minutes. It is estimated that about 15% of cardiac output reach the brain. Approximately 50 or 55 millimeters per 100 grams of brain tissue per minute. The brain receives its blood supply from 4 arterial trunks, 2 internal carotid arteries and 2 vertebral arteries. We are going to review the supratentorial arteries. The ICA is divided into 4 parts. C1, cervical portion, C2, Petros portion, C3, cavernous portion, and C4, or subarachnoid portion. This segment begins where the artery enters the subarachnoid space and terminates at the bifurcation into the anterior and middle cerebral arteries. This is the C4 segment. It's a supraclinoid carotid artery. Here we have the the optic nerve, third cranial nerve, and supraclinoid carotid artery. It is important to speak about the intracavernous segment of the internal carotid artery. It's impossible to explain supratentorial arteries without some explanation of the intracavernous segment of this important artery. In these pictures, we can see the third cranial nerve, fourth, and fifth, and its divisions in ophthalmic, maxillar, and mandibular. This is the gaser of ganglion gazers. The cavernous sinuses are located each side of the sella and pituitary gland. Here we have the sellar region, the anterior clinoid process, posterior clinoid process, and here we have the optic nerves, supraclinoid carotid arteries, the infundibulum of the pituitary gland, and clivus and middle fossa. This small nerve is fourth cranial nerve. If we remove some dura, we can see the pituitary gland, anterior portion, posterior portion, neurohypophysis, and we can see also the irrigation, the inferior hypophyseal artery that is coming from the meningohypophyseal trunk. This is third cranial nerve, sixth cranial nerve, and fifth cranial nerve. The cavernous sinus is defined as the dural space in which the cavernous segment of the internal carotid artery courses. This is also known as siphon, carotid siphon, and contains not only the cavernous carotid artery, but also a venous confluence that receives veins draining the orbit, like in this case, sylvian fissure, and middle and anterior fossa, and has free communication with the basilar, superior, and inferior petrosal and intercavernous sinuses. So here we have the inferolateral artery that is coming from the lateral aspect of intracavernous carotid artery. The oculomotor nerve, fourth and fifth cranial nerves. You can see in this picture the Parkinson's triangle. That this is formed between third and fourth cranial nerves. This is, okay, let's go to talk about the abducens nerve, courses on the medial side of the ophthalmic nerve. Between it and the internal carotid artery. This nerve is inside the cavernous sinus, sixth cranial nerve. This is intracavernous carotid artery. The nerves in the sinus wall or sinus are from superior to inferior, the third cranial nerve, fourth and fifth, and abducens nerve inside the cavernous sinus. If we remove the anterior clinoid process, we could see the paraclinoid segment of the carotid artery, internal carotid artery. These are some veins draining the orbit to this region in the clinoid process. There are 4 channels in the cavernous sinus, 4 in the middle fossa and 2 in the paraclival area. This is known as Parkinson's triangle. This is third, fourth, fifth. And if you separate this Parkinson's triangle, you can see the meningo-hypophyseal trunk. Parkinson described a triangle with the lateral wall of the cavernous sinus, through which the intracavernous portion of the carotid artery and its branches might be exposed for surgical treatment of carotid cavernous fistula. This is Parkinson's triangle between 4th and 5th cranial nerve. And here we have some small branches that are coming from the inferolateral carotid artery. This is a very small artery that is coming from the intracavernous carotid artery. Cavernous sinus triangles, we have a clinoidal triangle. This triangle is situated between the optic and oculomotor nerves. This triangle is exposed, removing the anterior clinoid process. Here we have this first triangle that described Dr. Roton. This is optic nerve, supraclinoid carotid artery, and this is ophthalmic artery, and this is the triangle, the first triangle. This is a third cranial nerve, and here we have 4th cranial nerve. Oculomotor triangle, 2 margins of this triangle are formed by the anterior and posterior petroclinal dural folds that extend to the Petros apex. The third side is formed by the interclinoidal dural fold that extends from the anterior to the posterior clinoid process. Supratrochlear triangle. This triangle is situated between the lower surface of this oculomotor nerve and the upper surface of the trochlear nerve. The infratrochlear triangle, also known as Parkinson's triangle, is located between the lower margin of the trochlear nerve in this side and the upper margin of the ophthalmic nerve. The origin of the meningo-hypophyseal trunk from the posterior bend are located in this triangle. This is a really beautiful artery. This meningo-hypophyseal trunk is giving rise to 3 or 4 small arteries. They are named as inferior hypophyseal artery, the meningeal dorsal artery, the tentorial artery, also known as Bernasconi Casinari, and sometimes is giving rise to a capsular artery, a very small artery. Here we have the trigeminal nerve, the Gasser ganglion of Gasser, and here you can recognize 3rd cranial nerve, 4th cranial nerve, and 5th cranial nerve. This is the intrapetrous segment of the internal carotid artery. Here we have the dorsal aspect of the cavernous sinus, the supraclinoid carotid artery, the intracavernous carotid, sixth nerve. And this is the interclinoid cavernous sinus, also known as coronary sinus. This is a pituitary gland, and this space communicates each one of the cavernous sinus, the venous compartment of each cavernous sinus. These are the posterior clinoid process, anterior clinoid, and here we have the ophthalmic artery. This is a video in which no, this is no, Parkinson's triangle is between fourth and fifth. And here we have the trigeminal nerve. Then we can see in here the great petrosal superficial nerve here. And above this, we can see the Kawas's triangle. This Kawas's triangle sometimes is it has a very thin osseous lamina, and sometimes it's very easy to open this Kawas's triangle. Here we have two strong ligaments. Here is the petrolingual ligament and Gruber ligament. This is sixth cranial nerve. The supraclinoid portion of the internal carotid artery, this artery is divided in four parts: C1, cervical portion; C2, Petros portion; cavernous portion; and supraclinoid portion. Here we have the supraclinoid segment of this artery. And C4, also known as C4, supraclinoid, begins where the artery emerges from the dura mater, forming the roof of the cavernous sinus. It enters the cranial cavity by passing along the medial side of the anterior clinoid process and below the optic nerve. Courses posteriorly, superior, and slightly lateral to reach the lateral side of the optic chiasma. At the end of the Sylvian fissure, giving rise to anterior cerebral artery and middle cerebral artery. The pre-bifurcation branches of C4 are the ophthalmic, anterior choroidal, posterior communicating arteries, perforating, and superior hypophyseal arteries. Segments of C4, ophthalmic, become anterior choroidal artery and ophthalmic segments. In this picture, we can see the supraclinoid carotid artery, optic nerves, the supraclinoid portion. This is the posterior communicating artery and hypoplastic posterior communicating artery. And this one is the anterior choroidal artery. And then we have the bifurcation of this middle cerebral artery. Here we have the brain stem, the third cranial nerve between superior cerebellar artery and posterior communicating artery. The anterior cerebral artery is the smaller of the terminal branches of internal carotid artery. Arises at the medial end of sylvian fissure, lateral to the optic chiasm, and below the anterior perforated substance. It courses anteromedially above the optic nerve or chiasma, and below the medial olfactory striate to enter the interhemispheric fissure. This is a nice picture to recognize the supraclinoid carotid artery, the optic nerves, the chiasm, optic chiasm, and the lamina terminalis. Here we have the A1 segment of anterior cerebral artery and M1 segment of middle cerebral artery. This segment of this anterior cerebral artery is giving rise to many small branches in this side. Superior hypophyseal artery and infundibular arteries is the largest of the branches and is often referred to superior hypophyseal artery. The ophthalmic artery is the first branch of C4. And this anterior cerebral artery is divided at the anterior communicating artery into two parts. Proximal, also known as pre-communicating, and distal, post-communicating. Proximal part extends from the origin to the ACOM and constitutes the A1 segment. The distal part is formed by A2, infracallosal, A3, precallosal, A4, supracallosal, and A5, posterocallosal segments. Here we have some small branches of A1 segment, and these small branches sometimes are coming from this anterior communicating artery. This is a small communicating artery that is giving rise to some anterior hypothalamic arteries, optic and chiasmatic arteries. This is A2 segment or post-communicating segment of anterior cerebral artery, and this is also known as recurrent artery of Hübner, this one. In this case, is coming from A2 segment, but sometimes is coming from A1 segment. The other one is this, the recurrent artery. A1 segment, anterior communicating arteries. The A1 courses above the optic nerve here to join the anterior communicating artery. Is this small communicating artery? The junction of the anterior communicating artery with the right and left. The A1 and A2 and the anterior communicating artery give rise to numerous basal perforating arteries. Hübner artery arises from each, could be A1 or A2. And here you can see this very interesting and small artery. This is known as anterior hypothalamic artery. There are some colleagues, some brain surgeons that try to divide the anterior communicating artery in order to have a much better view of the suprasellar region, some lesions in this part. So this is, of course, very useful to remove some suprasellar regions, but the brain surgeon needs to be very careful in order to avoid lesion this anterior hypothalamic artery, because this artery is going to the anterior nuclei of the hypothalamus, and the patient could be a loss of thermal activity. This is another video to see the anterior communicating artery. This is A1, left side, A1, right side. This is a very small communicating artery. And look these small branches that are coming from this anterior communicating artery. One of these is the anterior hypothalamic artery. In here we have the middle cerebral artery, and this is posterior communicating artery. Look how many branches are coming from these arteries. They are really numerous branches, small perforator branches. The distal or post-communicating part of the anterior cerebral artery begins at the anterior communicating artery and extends around the corpus callosum. This is corpus callosum to its termination. The distal anterior cerebral artery is divided in 4 segments: infracallosal, precallosal, supracallosal, and retrocallosal. A2 begins at the anterior communicating artery, passes anterior to the lamina terminalis, and terminates at the junction of the rostrum and genu of the corpus callosum. From here to here is the A2 segment. A3 is in front of genu or corpus callosum. A3 is in this part, and A4, the retrocallosal or postcallosal segment. This is another form, another way of the anterior communicating artery. This is A1, A1, A2, A2, and this is anterior communicating artery. Anterior communicating artery has too many variations, too many variants, anatomical variants. The pericallosal artery is a portion of the anterior cerebral artery distal to the anterior communicating artery around or near the corpus callosum. This is a pericallosal artery. The callosomarginal artery is the largest branch of the pericallosal artery and is defined as the artery that courses in or near the cingulate sulcus and gives rise to 2 or more major cortical branches. Here we have another anterior communicating artery, and this anterior communicating artery is giving rise to this big artery. You need to know precise knowledge of anatomy of arterial brains in order to remove some lesions. For example, this is a meningioma, and in this kind of lesions, you need to make a frontal craniotomy, but also a subfrontal access in order to remove all of this tumor. The access is very wide. This is a posterior or postoperative stage of this patient. This patient did very well doing this kind of surgery. This is an osteotomy. This is an osteotomy, fronto-orbito-ethmoidal osteotomy, in order to have a better access to the frontal part of anterior roof of skull base. We see this picture, and here we have a video in which
Victor,
excuse me?
You're okay there?
Excuse me?
No, we couldn't hear from you. That's why.
Okay, it's right?
All okay, but we can see it well.
Okay. It's okay?
Yep.
Okay. Middle cerebral arteries. Let's go to review middle cerebral artery. It's the largest and most complex of the cerebral arteries. Some of its branches are exposed in most operations in the supratentorial area. And in the past, surgical interest in the middle cerebral artery has been directed at avoiding damage to its branches during operations within its territory. This is M1, also known as, this is a sphenoidal segment, or M1. Salman, can you see the video? Can you hear me, Salman?
Yes, we can hear you. Yeah.
Video is okay? Okay.
Yeah, video is perfect.
Okay, supraclinoid carotid artery, posterior communicating artery. And here we have the anterior choroidal artery beside the optic tract. And these are lenticulous striates arteries. They are divided in 2 or 3 groups: medial, intermedial, and lateral groups. Here we could recognize two groups, medial and lateral. They are so. Here we have 10 arteries, 10 lenticular striates arteries, an early branch of M1, and this is bifurcation of M1. In this curve begins the M2 segment. MCA arises at the larger of the 2 terminal branches of the internal carotid artery. The diameter of middle cerebral artery at its origin ranged from 2 to 4.6 millimeters, almost twice that of the anterior cerebral artery. This is anterior and this is middle. Its origin is at the medial end of the sylvian fissure. This is sylvian fissure, lateral to the optic chiasm, below the anterior perforated substance. This is anterior perforated substance. As it passes below the anterior perforated substance, it gives rise to a series of perforating branches referred to as lenticulostriates arteries. This is M1. This is another nice, beautiful picture in order to see these arteries. This is posterior communicating. This is anterior choroidal artery, and this is M1, middle cerebral artery. The perforating branches of middle cerebral artery enter the anterior perforated substance and are called the lenticulostriates arteries. These arise from the pre-bifurcation part of M1 in every case. The MCA is divided into 4 segments: M1, sphenoidal; M2, insular; M3, opercular; and M4, cortical. M1 begins at the origin of middle cerebral artery and extends laterally within the depths of the sylvian fissure and terminates at the site of a 90-degree turn. So this is M2 and M1. Not this. The bifurcation not always end or begin at this curve, at this 90-degree turn. The segment begins at the genu of where the MCA Trongs passes over the lumen insulae. This is M2, known as insular segment, and terminates at the circular sulcus of the insula. The branches to the anterior frontal and anterior temporal areas cross only the anterior part of the insula, but the branches supplying the posterior cortical areas course in a nearly parallel but a diverging path across the length of the insula. This is insula. The M3 segment begins at the circular sulcus of the insula and ends at the surface of the sylvian fissure. These branches are forming the M3 segment closely adhered to the course over the surface of the frontoparietal and temporal opercula to reach the superficial part of sylvian fissure. This is a block of brain in which I remove the gray substance in order to see the white fibers of brain. This is temporal, frontal, and parietal. And here we can see the opercular segment of or also known as M3 segment. M3 segment, the branches directed to the brain above the sylvian fissure undergo 2 180-degree turns. The first turn is located at the circular sulcus at the end of the insula. Okay, the second degree turn is located at the external surface of the sylvian fissure in here. This is M4, cortical area of middle cerebral artery. Frontal, parietal, and temporal. The cortical area, M4, is supplied by the middle cerebral artery and is divided into 12 areas: orbitofrontal, prefrontal, precentral, and central area. And then we have anterior parietal area, posterior parietal area, angular area, and temporo-occipital area. Posterior temporal area, middle temporal area, anterior temporal area, and temporopolar area. Of course, it's very important to know brain arteries, anatomy of the brain arteries, to avoid lesion them in some surgical procedures. This is a giant meningioma. After the resection, we can see the supraclinoid carotid artery, M1 and A1 cerebral arteries. It's another view. And pre and post operative. So, this is a nice picture. Here we can see the optic nerves and chiasm, and then the optic tract, and this is the lateral geniculate body. Here we have a brain stem, mesencephalon. Here we have olfactory nerve, and then M1, M2. Temporal lobe was resected in order to see these arteries. This is opercular segment, this one, insular, opercular, and cortical segments. A nice picture in the insula. And after removing some gray substance, we can see the insula, the insular segment of a middle cerebral artery. As you can see, anatomy of brain arteries is beautiful, not only beautiful, also necessary in order to make surgical or endovascular procedures of these arteries. I am removing here a small part of gray substance. Then we have 12 areas reported by Dr. Roton in the M4 segment of middle cerebral artery. Again, insular segment, M2, opercular, M3, and cortical, M4. Let me, okay. I wanted to review brain arteries. First of all, in the supratentorial arteries. And I think in other session, we can review the infratentorial arteries and also the circle of Willis. Do you agree, Salman Sharif? I think arteries of brain is so much information, and that's the reason I divided into lectures.
Sure, I think we can definitely do that. I'd let Nicolai and Rocky take it from here. Yes?
Yeah, it was a great presentation, Victor, as usual, and great anatomy slides, and we have seen very interesting videos. Yeah, 1 hour is not enough to review the whole anatomy of the vessels of the brain. I agree completely with you. So we are waiting to see the next video of the P fossa of the posterior circulation and the circle of Willis. Thank you.
Dr. Perez has some beautiful videos that are available just on YouTube if they wanted to review that anatomy. And people spend their whole careers studying these blood vessels. 1 hour certainly doesn't do them justice.
Thank you, Dr. Daniel. Thank you so much for the comment.
I think, Victor, we're really grateful. It was a wonderful talk. So I think it's a great talk just before going to a clinical talk. Rocky, you want to take it from there and introduce our next speaker?
Yes, it's my pleasure to introduce Dr. Carollos. He did his medical training in Alexandria and then went to England for further specialty training. He finished a very prestigious skull-based fellowship out of University of Toronto. He's a senior consultant in England right now. And he's going to be talking to us about probably one of the more difficult pathologies that we face, arteriovenous malformations. Thank you for coming and speaking to the group, Dr. Carollos.
Thank you. Right, thank you very much. The talk is mostly anatomical, but in an applied manner for planning AVM surgery. I apologize, I gave this talk before. Some of you may have heard it, but it's mainly to see the value of anatomy that we have seen, the beautiful dissection from Victor, and to know what is the value of understanding all this anatomy to execute all surgery, not just AVM surgery. And as he emphasized, everyone should know the vascular anatomy of the brain. So the AVMs can look very complex, and the more you understand the anatomy, you can decipher them. And the whole idea, the more you know, is not to make your surgery complicated. On the contrary, the more you know, your technique should be simple, because simple surgery is less, carries less morbidity. So when we plan a surgery, that means that you exactly know what you are going to do before you start. That means these are the steps that you all know that you will do for an AVM surgery. You have to expose it, identify it, find the veins, find the location of the main feeders, which one on passage, which one feeds the nidus, where is the nidus, and what is the relationship to the brain. So when you open surgery the next day and you find this tangle of vessels, you have to know beforehand what are you going to see. And the most difficult is to find really where are the main feeders related to the brain, because it will take you to the nidus. And the most difficult part of AVM surgery complex is really to define the margins of the nidus. We will go so much into these details, and where are the white matter tracts, because they are not nicely dissected as in the cadaveric specimens. But don't forget, if you have a simple AVM, you just go around it and remove it. You don't have to make drama of simple operations, but this is mainly to decipher more complex cases. So AVMs to everyone looks like a tangle, a very complex, chaotic structure, disorganized. But how can you make sense out of it? How can you get order out of this chaos? And it is not really obvious by just looking, you have to know. And the fact is that AVMs, you have to remember, they are malformations of the capillary bed. And I have to emphasize that many times, that it's not a malformation of the arteries or the veins. Now, the arteries of the veins may look dilated, bizarre, tortuous, but in fact, it is the normal arteries, the normal veins in the normal locations that supplies the AVM. So every time you know the key to AVM surgery is that you must understand the normal vascular anatomy, because it's maintained and you will find some order as such. The arrangement, as we have seen, the vessels, the large vessels are the cisterns, sulci, and then they go to the cortex. Now, the cortical arrangement is where you know the names, like we have seen in the previous lecture, but you have to know exactly where they are on the brain. You can correlate where what you see on the angiogram that you'll find at surgery. And these vessels do go over the cortex in the sulci gyri, and then they perforate the cortex. Now, you don't see them normally, but in the AVM, because they are large, they supply the subcortical areas. So in a sense, they are perforators, but we call true perforators are perforators that goes directly from main vessels without giving cortical branches to the deep structures. You have to know the arrangement of the vessels around the ventricle. And in the brain, it is unique because not always the arteries travel with the veins. Some do, some don't. So, you know, you have an axillary artery with an axillary vein in the arm, but here you have veins not draining an area supplied by the artery, but they are not traveling together. So the key, the first part of the operation, before you touch the AVM, that you should apply a wide arachnoidal dissections and scrutinize all these vessels and define the subcortical segments to the origin when they penetrate the parenchyma. Now, the venous anatomy is most important. They are variable, but still have some order. Some are in the sulci, like the vein of Trochlear, the vein of Labe, the Sylvian veins. But also we have very tiny veins that goes through the cerebral mantle called transcerebral veins. You don't see them, they are very small, but in AVMs, they become enlarged, they become problematic, they go through the white matter tracts. The fact that you see them, they are not a new invention. They are there, but have become dilated because of the AVM. And again, around the ventricle, it's important to know your anatomy. So this is just an exercise to know how do you convert your angiographic vision and to know where's the relationship of what you see on an angiogram to the normal anatomy. So when we plan AVMs, we rely on MRI scans. But the problem with MRI scans, they are very good. They will show you the cortical locations, the white matter tracts, the eloquence. But when it comes to the arteries, they just show you some flow voids. You don't know which ones are the veins, the arteries, but you can predict if you know a particular location, so you predict it's a normal artery. So if you have an AVM in the temporal poles, then it is a temporopolar branch of the M2. So you know as a prediction, but you cannot see them properly. And by the way, I showed that several times. This is a photograph I took myself. This is the first ever MRI scan to be used in humans, and it's housed in the Aberdeen Royal Infirmary in Scotland. But angiograms are important for AVMs. This is what the radiologist will tell you, that we all know. It will give you the size, location, and so on. But when you look at the angiogram, you should have a surgical eye, because this is what you know. You want to see. You will see the feeders, and you have to imagine where they are on the brain itself, because that's what you are going to operate. And then when you look at the angiogram, look at all the images, because sometimes AVMs are between two territories, like a superior frontal gyrus AVM. It will be supplied by branches coming from the callosal-marginal of the ACA and also from the cortical branches of the MCA. So they are between vessels. And then have in your mind, with several views, go through the arterial vein phase, venous phase, and the AVMs will look like a sphere with all the arteries going into it in one pole and veins, and you establish how you can rotate it in the brain. There are 3D models that you rotate it for you, and you look at it from several angles, but that's not enough, because you have to put all that with the surrounding brain and white matter tracts. And this is the skill you have to teach your eyes when you plan AVM surgery. So in summary, you use the MRI scan, you can predict where the feeders are, knowing where it is, but you can look at the angiogram and predict. It's a difficult exercise to predict where is the location of the nidus by just looking on the angiogram without even doing an MRI scan. The other aspect of AVM surgery, because most of the AVM surgery, luckily they are cortical and subcortical, the ones you operate on, but they do go deep and they go towards the ventricle. And what you have is the white matter tracts. Now, the Spencer-Martin classification tells you eloquence according to the cortex. There is plasticity if you damage the cortex, but if you damage white matter tracts, your deficit are permanent. You don't see this appearance when you operate. It's all look like white mush to you, but you have to know where is the location of the deep white matter tracts. And for example, this is the superior longitudinal fasciculus, and the arcuate fasciculus is related to it, deeper to it. But they are deep to the U fibers of the cortex. That means the other imperative part of complex AVM surgery, apart from arachnoidal dissection, that you should dissect adjacent to the AVM the depth of the whole sulcus, because it will give you a reference by depth, because you know deeper to the sulcus, you'll have some U fibers, and straight will be the white matter tract. So if you're operating on here, when you go deeper to the adjacent sulcus, you know that you will near the white matter tract because you don't see them. So you have to estimate them. So the two advice for complex AVM surgery: before you touch the nidus, just open the sulci and open the subarachnoid space with the vessels. You have to know all the white matter tracts. Of course, this is not the purpose of this talk, similar to any glioma surgeon. And similar in the posterior fossa, you should know where is the deep structure, like in the cerebellum, where is the dentate nucleus, and so on. So the most difficult part of AVM surgery is to define the nidus. And to define the nidus, you have to follow the vessels to the nidus. So if you know what they look like, you follow them, and it will tell you where is the origin of the nidus. Because around the nidus, you have a lot of vessels and changes. And if you are not keeping to the nidus, you will have either residual AVM, which bleeds into the cortex, or you can damage the surrounding structures. So knowing where the feeders are is not just for control. Of course, control is important, but it will take you to the margins of the nidus. And this is what we call edging, like the neurophysiologist and ulnar nerves, that you go bit by bit until you find the edge of the nidus. Second, all AVMs looks like a cone, ice cream cone. This is the superficial surface. Subcortically, it goes like an iceberg, so you don't dissect straight into it. You go tangential to it, and once you go deep, you will go either circumferentially around the cone, because the nose of the cone goes towards the ventricle and ependymal vessels. Now, some surgeons, like Professor Michael Morgan, will advocate that you go in one area directly to the nose of the cone, because this is the most difficult arteries to control, and then go from deep to superficial. But most of surgeons go circumferentially around them. So here is, when you look at the angiogram, you have to identify a pattern, because you go at surgery and you find this. You don't know what is what. So if you know from your angiograms that there is a branch that turns, even for the small AVM, and gives a branch before. So for example, here there is a feeder, gives a branch here. Then if you follow the arteries from distal, then you will know that once you come to here, you will get you to the edge of the nidus. And similar on all areas, the vein will take you to the main nidus, but the arteries will define the edge. And don't forget that all the edge of the nidus have tiny vessels going into it. So it's not only important to control that, but everything around it. Don't remove it as a tumor. And this brings us to the perinatal zone, because it's an area around the nidus that is very difficult in complex AVMs. In small AVMs, it's not a problem. You can see it and go around them. But in complex AVMs, you have two types of nidus. You can have a compact nidus like this, or a diffuse nidus with perinatal changes, and you don't know how to define it. So what you do, don't forget that every part has vessels in it. This is not a cavernoma or hemangioblastoma. There is tiny vessels all around. It's not blind spots. So you have to be very careful with the control of the tiny feeders all around. Now, if you go wide around the nidus, it may not look very elegant, but it's very effective because you encounter less vessels. And not only that, in fact, the perinatal vessels, if you include them, provided they are not in eloquent area, it's better because they don't remodel. We studied that with Professor Michael Morgan in Cambridge. They take a long time to remodel, so they can have intra-operative or post-operative hemorrhage. So if you go wide, it is advantageous. It may not look beautiful on your operative video, but it's advantageous. But when it comes near eloquent areas, like the white matter tracts, you really, really have to be close to the perinatal dissection. So you can have variation around how radical you are when you dissect a nidus. And of course, the cases that has previous hemorrhage are more easier than the unruptured one because there is already a nice gliotic plane around it, similar to the brainstem cavernomas that breathe. So you go around it, it's easier to define than new ones. A lot of the suboptimal outcome because you either underestimate how difficult the AVM is, or you think it's so complicated and you make further unnecessary maneuvers. And you underestimate what is your morbidity. And it's mostly related to white matter tracts and vascular injury. So the key to perioperative planning is that you locate the feeders on an angiogram, know how to identify them, follow them, and trace them to the nidus. And this will require wide subarachnoid dissection. And also you have to establish where is the related white matter tracts. And as I told you, one of the tricks is to know the relation to the deep of the sulci, to the depth of the sulci. So this has already been covered by Victor very nicely, but we will go through the vessels, and what I put here are the branches and where you find them in the brain. So the M3 are the opercular branches that is coming through the frontal and temporal operculum and parietal operculum, and then the cortical one are the M4s. And the M4s are coming from two trunks, the superior trunk and inferior trunk. The superior trunk gives the first one is the lateral frontopolar vessels going to the lateral surface of frontal pole. And then you have multiple prefrontal ones. They can be multiple, they can be variable, and they emerge from the operculum and travel up to the superior frontal gyrus. The pre-Rolandic is usually adjacent to the precentral sulcus, the Rolandic in the central sulcus, and then from the superior trunk you get the anterior parietal, which adjacent to the post-central sulcus to go to the superior and a little bit of the supramarginal gyrus, so superior parietal lobule. Now the lower trunks, the first branch it gives will be the posterior superior parietal lobule, which is the posterior parietal branch. So you have anterior from the upper trunk, posterior from the lower trunk, and then an angular one to the angular gyrus and a bit of the supramarginal. So you find it adjacent to the this is the intraparietal sulcus. So this is the supramarginal angular. So you'll find it adjacent to this area. Then from the temporal, you get the posterior temporal. There could be a middle temporal and an anterior temporal. They are supplying the lateral surface of the temporal lobe. And then very anterior on the temporal pole, you get the temporopolar branch. This has been covered brilliantly. I don't have to repeat it, but similarly, the first branch of the M2 related to AVMs will be the fronto-orbital and the frontopolar branches from the proximal A2s to the both orbital surface and towards the frontal pole. And then you get the pericallosal with all its segments, the A3, A4, and A5, and they end near the paracentral lobule. So they supply the cingulate and paracentral lobule. The callosomarginal goes to the cingulate sulcus, so you know how to identify them, and they supply the SMA area and the paracentral lobule, but they give branches that goes and anastomose with the other sides, because this, don't forget, this is an extension of the superior frontal gyrus. A very good location for AVMs. Posterior cerebral is very important to identify. It's coming from the basilar. And if you look at the AP, the first part will be the interpeduncular systems here. Then it goes around the cisterna ambiens. This is the P2 segment. And you can see here, the two westing here, it is when they reach near between the cisterna ambiens and the quadrigeminal area. And then they go supratentorial here and end in two branches, one in the parieto-occipital sulcus and one in the calcarine fissure. So the ones related to the AVM, you see very faint vessels, but when you have an AVM in the tentorial surface of the temporal lobe, these vessels become large. And what we have from the P2, the medial one that goes to the choroid fissure will be the lateral posterior choroidal, but the ones on the tentorial surface of the temporal lobe, you get an anterior temporal and a posterior temporal, and they are just traveling from the cisterna ambiens on the superior surface of the tentorium. This is how you locate them. And then they will enter the cortex and supply subcortical AVM here. Near the end, between going to the quadrigeminal system, they give a small branch to the splenium or posterior callosal, called the splenian artery or posterior callosal. And if you are doing corpus callosum AVM, this is an important artery. And then the two terminal branches, they go to the adjacent named fissures and sulci, as you can see here. So if you go in the frontal lobe AVMs, then you look at the frontal lobe, it has a lateral surface, a pole, and a medial surface, and an orbital surface. And these are the vessels that supply them. So the MCA supply most of them, and you can see the prefrontal, they are multiple, the prerolandic, rolandic, and the posterior parietal not included in the frontal lobe. And then the frontal pole will have the frontopolar and the frontoorbital as such. What is important on these when you do frontal AVMs is to identify where is the opercular branches or MC. Now, when we do angiograms, so this is the example of a frontal AVM, all the other branches do not fill properly because there is shunting of the blood. But what you can see here, you first identify this area. You can see because the operculum is causing a lot of turns that we already seen in the last lectures. So they appear like semicircles or loops. So this is the opercular part. So this is the origin of the sylvian fissure here. So you can identify that this is probably, well, this is a pre-motor AVM because it's above the operculum, probably in the middle frontal gyrus. And you can see the poles. That there is a vein here will take you to the superior pole, this artery to the anterior surface of the nidus. There is another draining vein which defines the posterior part of the AVM. So looking into the angiogram, you can tell where it is and how to reach the nidus. And if there is a deep extension here beyond the sulci, it will reach the superior longitudinal fasciculus. So if you look into anatomy, the same AVMs, it is here, and it's correctly, as we predicted, in the middle frontal gyrus in the premotor area. And if it is in the deep, it will affect the superior longitudinal fasciculus. So it will be supplied. This is the operculum. It will be located here. And this will be the prefrontal branches of M4. This one, it is more posterior, and on the AP, supplied by the most lateral branch, which is the rolandic branch. So this one is really in the motor area. But because this is the operculum, it is in the lower part of the precentral gyrus, which is luckily the face area. It is bilaterally represented, so you don't get measured deficit if you cause a loss of damage, but try not to. However, the white matter track deep to it is the corona radiata. It is not at the depth, these are projection fiber, it's not at the depth of the U fiber. So any deep extension of motor cortical AVM can not only damage the motor cortex, but also the corona radiata as well. So this is an exception. This is an opercular one because you can see the turning of the fibers. So this is in the frontal operculum of the inferior frontal gyrus. And you can see all these veins will define to you the edges of the nidus. So when you dissect the arachnoid, follow them, you will have an idea where is the edge of the nidus. Anything going from below will be the lower edge of the nidus. And again, this one is deeper to the language area, so can affect the arcuate fasciculus or the motor output of language. So here on anatomy, see how this is the insula, and this is why the opercular branches appear circular or looping, because they are around the operculum in here, and the AVM is located here in the frontal operculum. And deep to it, you have the superior longitudinal fasciculus, but the deep part that is important is the arcuate, which is connecting your motor to the receptive area of language and speech. The frontal pole of the AVM is the frontal pole of the frontal lobe is interesting because it is at the end. So medially, it is supplied by the frontopolar branch of the A2, while on the lateral surface, it's supplied by the lateral orbital branch of the M4, sorry, A2 and M4. So if you look at this This is one AVM, this is another one. So this one is supplied by the M4, and this one is supplied by the ACA. And the way to know it, if you look at the AP, well, one is right and one is left, I know that, but this is the silhouette of the anterior internal carotid. This one is lateral, so it's more likely to be supplied by the MCA. This one is medial to the carotid line, so that's why it is on the medial frontal pole. So just looking from on the angiogram, you can predict where it is. I'm not telling you not to do MRIs at all, but I'm telling you this is an exercise. The medial one, we have gone through them, and this one, as you can predict, is coming from the pericallosal, and it's adjacent to the SMA, the supplementary motor area. So you expect these patients to have transient mutism and hemiparesis after surgery. But if it is deep, it will take the white matter track, the white matter of the cingulum, so they can have additional limbic manifestation and confusion. So looking at that, so you know that when you do interhemispheric, that the depth of your fulx will be adjacent more or less to the callosomarginal or cingulate sulcus, and deeper to it will be the pericallosal. So for this one, the vein is more posterior, so you come at the more anterior trajectory, not to damage the vein, leave it to last, find the pericallosal, follow the pericallosal, it will take you to this margin, follow the vein, it will take you to the superior pole, and if there is any other branches, try to identify the nidus and remove it. This is the temporal lobe. We have, you can just read the table. We have already gone through them. It has a lateral surface, a pole, and a tentorial surface. And the tentorial surface is mainly supplied by the branches of the P2 of the PCA, which will be the anterior posterior temporal, and more medially, the medial structures near the choroidal fissure will have the lateral posterior choroidal and anterior choroidal artery going near the choroidal fissure and adjacent to the lateral geniculate body. So if you have this AVM, it's a simple AVM. It is coming just behind, after the operculum. So it is supplied by the lower trunk, which this is a posterior temporal artery and draining towards the transverse sinus. So this AVM is easy to locate just looking by the angiogram, and you know to get proximal control, you may have to open the distal part of the sylvian fissure to get proximal control of this main artery. And deeply, if it is on the left, it will affect the horizontal part of the arcuate fasciculus going to the receptive area of the language and the Wernicke's area. But if it's, you really go very deep, you will affect the optic radiation and cause homonymous hemianopia. This AVM, again, is the temporal lobe. It is coming from the M2. This is the anterior temporal or polar branches. But what is peculiar about it, that is draining to the vein of Rosenthal. So this AVM is anterior lateral temporal, but also has extension over the tentorial surface. Otherwise, the drainage will not have gone to the vein of Rosenthal. So you can tell there is a wealth of information looking at an angiogram. And for this one, again, you may open the sylvian fissure. It does not go posterior enough to take the Mayer's loop, but if you have a wide dissections, you may affect the Mayer loop as well. So you got the idea how we can predict what the location from anatomy. Here is an example how the P2 branches become enlarged. So this one, you can have an anterior temporal branch that is enlarged. So you know that this AVM is involving the tentorial surface of the temporal lobe. So if you find this vessel, you have to go subtemporal to the cisterna ambiens, and you follow this on the tentorial surface. Of course, you don't need to do that because it requires a lot of retraction, but anatomically it is here. So this is the anterior temporal branch coming from the cisterna magna of P2, which is hidden behind here. So this is exactly where the AVM is, and this is the blood supply to it. And the white matter tract related here would be the ILF, which is involved with facial recognition and so on. This is a similar one. So just to give you the idea, with again a very enlarged anterior and posterior temporal branch, because it's located more posterior than the last one on the tentorial surface. Again, this is the anatomical view. This one is more difficult because here is your P2, but it's not lateral, it's medial. and it's draining to the vein of Rosenthal towards the vein of Galen. So this one is in the parahippocampal gyrus, possibly affecting the choroidal fissure and hippocampus, because we know there is a blush from the anterior choroidal artery as well. So this one is located in the parahippocampal gyrus, and the morbidity will be related to the hippocampus and memory if you go deep into the white matter tract. And again, here to demonstrate where it is exactly, it is located here in the parahippocampal gyrus, and this is adjacent, this is the temporal horn, and this is the choroidal fissure. And this is the P2, and it's getting branches from the parahippocampal gyrus here. And the way it drains to the vein of Rosenthal, because the vein of Rosenthal starts as the anterior peripheral substance, drains the lower part, and it's joined by one of the ventricular veins adjacent to the hippocampus. So this is the draining vein going to the vein of Rosenthal to the deep veins. Parietal lobe is easier. They are lateral. You have an anterior and angular and posterior parietal branches, but also on the medial side, the distal part of the parieto-occipital gives the paracentral lobule and the superior parietal lobule as well. So this one is located in the supramarginal gyrus, and you can see it is from the inferior trunk. This is the posterior parietal branch, which usually goes up, and if it was more posterior, it will involve the angular branch as well. So you can tell where it is. It's just adjacent to the parietal operculum in the supramarginal gyrus. And if it is on the left, will affect the speech area in the cortex and deeper the arcuate fasciculus. And it's here located around here, supramarginal, which is here. And this is the arcuate fasciculus. No, this is the SLF. The arcuate fasciculus is deeper to that. And again, on the medial surface, it will be supplied in the paracentral lobule, which has the leg area, by both. This is the carotid, this is the pericallosal, so the distal A5 will supply it, and also the parieto-occipital branch of the P2, which is coming here. So this is the location of the AVM, and again, if you go deep, you'll get the corona radiata. This is another example. You got the idea. This is the P2, and this is the calcarine branch. So this is an AVM. Really, here is the wasting. So I told you the wasting on the angiogram. So this is where it's PCA is traveling on the above the tentorium, and it's in the calcarine fissure. So this AVM is as a primary area of vision. Cerebellum is very important because we do a lot of AVMs. It has a suboccipital surface, a tentorial surface, and a petrosal surface. So in my first 176, 1/4 were cerebellar. So it's important. So you have to know the pica loops to identify the more common flow aneurysm. But if we look at the arterial system, this is how I looked at it. So the suboccipital surface has the tonsil and vermis. Now the pica, the posterior inferior cerebellar, will give some branches to the suboccipital surface. But you have to appreciate that the superior cerebellar artery on the tentorial surface is the main supply to the cerebellum, to the extent that not only it supplies the tentorial surface, it supplies the lateral part of the suboccipital cerebellum as well. But the vermis and the tonsil have a long branch that goes up to the superior vermis. So the superior vermis is supplied by both the pica and the superior cerebellar. As you can see here, that's what I put to you. The lower part of the vermis is pica. The upper part of the vermis is still pica, because the pica give a very large and long midline artery to the tonsil and superior cerebellar. The petrosal surface is supplied by the post-meatal part of the ica, and lower part near the flocculus will be another contribution from the pica. Now the veins here is an example that they don't follow the arteries, and it's important to identify them. So I divided them into midline, superficial and deep, paramedial, and lateral. So they are not following the arteries at all. So the midlines, they all go towards the straight sinus, not necessarily directly, some of them through the tentorium and then the straight sinus, deeper in the front will going directly to the galenic system, while the paramedian parts are mainly all going up to towards the tentorium, even from lower down here. And the petrosal ones, the lateral ones, will go to the petrosal vein. But when you have an AVM lower down, don't forget that the petrosal vein may be draining other important parts, including a large pontine vein. So try, if you must, occlude it. Don't occlude it means the nidus not at its end of the drainage, not affect the pons drainage. These are examples. This is coming from the superior cerebellar vessels. This is coming from the petrosal. You can see very dilated ICA vessels, which we don't see, and draining upwards, as I told you, towards the straight sinus and tentorium. And this was the last AVM. You can see here the ICA loop in the meatus, and it's near the flocculus and on the petrosal surface. You have to recognize deep AVMs, mainly not to operate on them sometimes, but what's the problem with deep AVMs? That the perforators become very dilated. This is the lenticular striate, and you can see it traced up to the corona radiata here. Because it's dilated, because you have a small nidus here of an AVM in the white. So the problem with deep AVMs is that they involved all the white matter tracts. So that's why when you see a perforator contributing to an AVM, you have to be very careful how to limit your damage to the white matter tracts. This is the insula, and you know the blood supply of the insula we have seen from the M2. And if you look at this one, you cannot tell if it is opercular or not, but if you look at the lateral, the AP, this is the MCA, and it is medial to the M2s, that's why it is in the insula. The Sylvian fissure is more lateral. The thalamus has a distinct blood supply. It has an anterior group, which is coming from the P1, which is the thalamo perforators, and another group coming from the P2, and these are the thalamo-geniculate perforators. And they appear flame-shaped. So this is an AVM that involves the thalamus, lateral thalamus, and a little bit of the parahippocampal gyrus. You may or may not wish to operate on that. So to conclude, the white matter tract dissection is difficult. So when you have a bleeding AVM with a hematoma, we have looked at our experience, and I continue to do that in a lot of the AVMs. Of course, some of them you have to resect the AVM with the acute hematoma, but try not to. But if you leave the hematoma to liquefy, it will dissect the nidus for you, and you can include more complex ones. So if you have a liquefying hematoma in a good location around the nidus, provided you get an angiogram and you can resect it, don't let the hematoma disappear. Wait for a week or 10 days when it becomes liquefied, and use it for dissection. So here, this is a common problem. You all face it on emergency. You have this hematoma. What you do with it if you have a suspected AVM? First, if you don't have an angiogram, don't touch the AVM. Just deal with the hematoma. So if you really have to do it acutely, a lot of them can tolerate it and wait. Then if you have a simple AVM, remove the AVM with your hematoma. If not, evacuate the hematoma only. If you have a complex AVM and you are afraid to go through the AVM, you can just do an emergency decompressive craniectomy. But if they are stable, most people will wait and do an elective AVM resection. But sometimes you can make use of this cavity. The people have concerns because when you go through the cavity in the acute stage, you cause worse deficits and you can leave a residual. That's why in our paper, we looked at the experience and neither of that happened. We had good resection rate and very little added deficit, not because of the skill of the surgeon, but because of the hematoma makes it easy. Like all these hematomas can take you to deep nidus like this one, and have no time to go through it, or they have dissected the deep part of your nidus. You know, I tell you, all the deep dissection is already done by this cavity, as you can see in all of these ones. So it dissects the caudate out of this one, and all you go is dissect the superficial part. It makes the operation easy. But don't do anything without an angiogram, because what you look to you is an AVM could be just dilated veins from a dural fistula, and the treatment is absolutely different. You don't attack the arterial parts. So don't do emergency AVM surgery without an angiogram. So the takeaway messages from this talk is that the preoperative mental planning is very important. You are not going to explore without knowledge before. So always the normal anatomy will help you. Normal anatomy of the cortical vessels is very important to everyone, not just vascular surgeon. When you do your metastasis, gliomas, and so on. And similarly, brain anatomy is important to the vascular surgeons as well, not just the glioma surgeons. And the more you know the location of the normal anatomical structure, you have a pattern in your head. So all AVMs fits into pattern recognition. So if you see one, you know more or less where you will find the feeders and draining veins. Always use your vein, leave it intact, but it will guide you because it's the most superficial structure, it's arterialized. It will guide you to the pathway to a subcortical nidus if it is deep, but use the arteries not to control them. As I told you, just use it as a roadmap to outline the margins of the AVM. And the fact that these vessels are in a normal locations, you can know where you will find them, in which sulcus, which gyrus, but also because they are having distinct morphology, they are dilated and bizarre from the AVM, so you can recognize them easily and will make any AVM, complex AVM, easier to do. So in conclusion, AVMs that are simple, don't make a drama out of it, just go around it and remove it. But the complex one, you have to know the knowledge of the brain, knowledge of the vessels. Whatever your specialty is, you can subspecialize your practice, but don't subspecialize your knowledge. Just to end the talk, does anyone, I'll leave you to pause a little bit. Can you tell me what is this lesion? Of course, you are not, I cannot hear you, but this is the ophthalmic artery, which gives the anterior posterior ethmoidal artery. It is a location for dural fistula and the anterior fossa, which drain to the sagittal sinus, but no, this one is draining to the superior ophthalmic vein. So this is the unique structure. This is not a dural fistula. This is an AVM inside the orbit. So this is an orbital AVM and not a dural fistula. Thank you very much.
Thank you, Ramesh. Great talk. I'll just see if Nikolai, are you there?
Yes.
Yes. So carry on, man. And where is, I don't see Rocky here.
Yeah, so Ramesh, it was amazing presentation. It was great knowledge, and especially having in mind that less and less people are doing that nowadays. We rely more and more on endovascular treatment. Unfortunately, not all of them can be treated endovascularly, and because we don't operate them so much, there is nobody to operate them, and it is good that people like you still keep the knowledge. I wanted to ask you, what is your take on ICG? Do you use that in your practice, ICG, when you are operating AVMs?
We do it for videos, but it does not, very rarely it helped. In fact, the only ones it helped was to find a very small nidus, because there were superficial vessels, we did not know which directions they are going. So we use the ICG to tell us which direction the flow. There was an arterial vein, and I found it. But for the large ones, I don't rely on the ICG. In aneurysm surgery, we rely so much on ICG, but in AVM, I did not find it that helpful. But this is personal. I know others use it.
Yeah, maybe people which are not as experienced as you are, they can use ICG to maybe differentiate venous arterial, and also arterialized veins. With ICG
I agree with Nikolai. Once you open up the dura, you can do a quick ICG run. And if you're not sure if you're looking at vein or artery, it can at least show you the arterialized vein in the beginning. And as everyone knows, you want to preserve that in an AVM surgery.
Perfect. Thank you.
Yeah, I think in old days, the way to differentiate between vein and arteries was very simple. Use any bayonet forceps and see the flow, which way flow. You take the flow away and see which way the flow is, and then it's artery or vein. So that's how I was trained in good old time. One thing I wanted to ask, you haven't mentioned anything about grading of these AVMs. And do you use the grading of AVMs in order to decide, are you going to operate, or are you going to send them for something else?
Yes. Yeah, so I didn't put it in this talk. So the first part before you tackle an AVM, because there is no plan B. Once you're in surgery, there is no plan B in AVM. It's either all or none. So don't underestimate it. So to get the magnitude, you have to rely on the Spetzler-Pons or Spetzler-Martin classification, and most people would not do anything with grade 4 and 5. The only part that we modify a little bit is what is eloquence.
Yeah. Because
the eloquence was in the original classification all to do with the cortex. In fact, most of the visual field deficits are not from the primary visual cortex. It's all from the optic radiation in different areas. And then we know more that Broca's area may not exist. It's all to do with the IFOF, semantic paraphasias, and so on. So when you do insular AVM, so these are a new areas that we learned from the glioma surgeons. But the problem, don't underestimate an AVM. Otherwise, you will be stuck. But on the other hand, don't overestimate it, because there are AVMs that can be made simple. And if you know more, the technique has to be simple. If you are doing an operation that is so technically demanding, better not to do it. It has to be a simple technique. And that's why a lot of them, when we use the hematoma, the liquefying hematoma, if you look, some of them were the original classification of grade 3 or even 4, but the surgery was so simple because the hematoma has dissected it for you. So you can take advantage of something to make your technique simple.
And if I can ask another question about image-guided surgery, using the MRI, knowing exactly where the nidus is, even if it's small, image guidance work for you?
Yeah, you can use it, but don't make the mistake to make the exposure small. Because you need, as I said, the key to it is to have a wide subarachnoid dissection to get the origin of the vessels to take you like a roadmap to the margin. But it's useful, of course, around the vertex on the top, a callosal one, they can be used, yeah.
Okay, brilliant. Shall we, if you have any more questions, please raise your hands. We'll unmute you, and the moderators can unmute you and get you to speak. In the meantime, we can have a look at the multiple choice questions and see how people have filled. This is post the lectures. So let's see what they have done. Can we please see the multiple choice questions now?
Sure, sir. Can you see?
Yeah, so we get Victor. Do you want to read your multiple choice questions yourself? You sent us 5 of these. Can we just unmute Victor, please?
Yes.
Okay, brilliant.
The pre-bifurcation branches of the C4, I mean the supraclavius carotid artery, are the ophthalmic arteries, posterior communicating arteries, and superior hypophyseal arteries. And the answer is?
Yeah, can we go to the response, please? Just if you play the response instead of seeing the questions. No, just press on the response on the top, yeah? Just press here. Yes, please.
Anterior choroidal artery, is 76% posterior and anterior. This is right, anterior choroidal artery.
Good, Victor. You taught us well.
The cerebral blood flow is 30 millimeters per 100 grams of brain tissue, the second 50, the third 70, and none of the above. The correct is in color red, 62% were right.
Good.
The artery that supplies the third, fourth, fifth, and sixth cranial nerves is Bernasconi Casinari. Most of you put this one. Dorsal meningeal is in color red, and inferolateral artery. The right is in color yellow, is inferolateral artery. Most of you put 54, and that is not correct. The lateral aspect of the cavernous sinus is irrigated by the inferolateral artery.
Yeah, you showed it very beautifully.
Yeah, anterior hypothalamic artery is coming from posterior communicating anterior choroidal ACOM. ACOM was the right answer. Most of you put this answer. Next is how many branches are described in cortical segment of middle cerebral artery. I cannot see completely.
Can you please go up?
The sheet.
Meg, can you please move this up? Thank you.
Okay. Thank you. Most of you put 12 are correct. Are right. Yellow is the answer. You want me to read this also? I think these are the questions of Dr. Rames.
No, these were questions made by one of my residents. So, Rocky, you want to take it from there? Maybe you can read the rest of them.
Sure.
Yes.
Well, being divided into its terminal branches, the ICA gives rise to the ACA and MCA. The initial part of that ACA lies in front of what area? And so the choices are pituitary gland, lamina terminalis, fornix, or corpus callosum. Who did these questions?
One of my residents.
Okay. So the answer, 55% answered the lamina terminalis, which is that the correct answer? While being divided, I think that's right. Fornix is more posterior. Corpus callosum is a different area.
Agree.
Which structure is not supplied by the anterior choroidal artery? Globus pallidus, the internal capsule, medial geniculate body, or the optic tract. Looks like there's a division in the answers here, almost a third in the various ones. The anterior choroidal artery usually does the internal, usually treats the internal capsule. You get the homonymous hemianopsia, the hemiparesis, and hemianesthesia, the 3 H's, if you get anterior choroidal artery. What is the correct answer here? Optic tract gets affected, internal capsule gets affected, the globus pallidus gets affected.
Is that correct, Victor?
Well, choroidal artery is divided in 2 segments, the plexal and cisternal segment. So it supplies the optic tract and lateral geniculate body, but globus pallidus and genu of internal capsule are irrigated, some lenticular striates. I think could be medial geniculate body, could be.
Yeah, agree.
Might be more the thalamo perforator.
Okay.
The carotid siphon does not include, and it looks like 60% answered the communicating segment. Everything else is distal, hypophyseal, cavernous, and ophthalmic.
Okay, good.
What percentage of population of fetal posterior circulation? It looks like people are sort of divided here. Yeah, about 30% will have a normal circle of Willis.
So these are difficult questions now.
Yeah, pica, and it's all divided again, 20%, 30%. Pica, it arises 20 millimeters distal to the vertebral artery, where it becomes intradural. It rises 5 millimeters distal to the point where it becomes intradural, 10 or 15. There's a big variation of whether a pica is intradural, extradural that you're looking at an angiogram, and then you have to understand the different segments. Dr. Perez, what do you think the answer is?
Well, it's difficult. In my experience, I have seen pica coming from ICA, a main trunk coming from basilar artery, and it's giving rise to both of them, pica and ICA. But in this question, I think could be 10 or 15 millimeters. I think it depends of the study that you review. I don't know.
I agree. I think it's between 10 to 15. I think, this is obviously the questions were made by residents, so I apologize. I didn't look into that.
Yeah.
Okay. So
Okay.
next, we have to make sure.
Answer in the orange is right.
Like in medicine, it depends.
Farhan, you made these questions, so you should be able to answer these.
Yes, sir.
So you read this and you tell us why you put these questions. Why would you make it so complex?
So the lectures are so good, so we should know.
All right. Okay, so you want to read these, Farhan? You do this for us.
Which is not a segment of PCA? Peduncular, ambient, crural, or quadrigeminal? And the right answer is crural, which 29% of the people answered. The next question is, which is the most common type of persistent fetal anastomosis? Trigeminal, otic, hypoglossal, or proatlantal? And the most people answered right, which is 52% trigeminal. Area not supplied by the recurrent artery of AVM. Head of caudate, putamen, globus pallidus, and anterior internal capsule. And the right answer is globus pallidus. And very almost answers are, all of them are 50-50. Absent or hypoplastic A1 occurs in, it occurs in 25% of the. So we have 17% people got it right. Next question.
You should have sent these questions to Victor, so you could have put in his talk.
Name the fourth branch in ascending order arising from external carotid artery. And most of the people got it right, which is 43% facial artery. What segment is immediately after cavernous segment of internal carotid artery? And that is the glenoidal segment, and most of the people got it right again. Structure not supplied by anterior circulation. Corpus callosum, thalamus, fornix, and pituitary. Most of the people got it right again, which is 50% thalamus. This is a long question actually, having a scenario in it. A 50-year-old male, known case of diabetes and hypertension, presented in emergency with history of sudden onset severe headache. There are signs of meningism, diplopia, memory disturbance, and decreased intellectual capacity. PCS is 15/50, and there is no water deficit. CT brain shows subarachnoid hemorrhage with mild hydrocephalus. Which segment which we expect having a aneurysm in it? And the answer actually is M3 segment of MCA, and very little people got it right. Can we go up? Yes. The next question is a 65-year-old male, diabetic, hypertensive, smoker, history of severe 3 years ago. He is on aspirin, came to emergency with neck pain, diplopia, vertigo, and feeling of disbalance. Patient suffers a fall due to unsteady gait and acquires a deep laceration on the forehead. On the evaluation, patient has gross horizontal nystagmus and a fast component towards the right. Which arterial territory is involved? And the answer is left ICA. And almost the second best answer comes out to be this.
I think ignore these long questions. I don't think it's fair for people to be solving this when you're doing these webinars.
This is the last one.
Okay, let's do this.
A 50-year-old male, known case of hepatoma, bedbound for last 4 months, had massive ascites and hepatorenal syndrome. Came to emergency with sudden onset visual disturbance and right-sided weakness. TCS is 15 out of 15, but there is he's not following commands from the left eye, especially in the medially and upwards. His pupil is anesogoric and left pupil is dilated. There is ptosis on the left side as well. Power is 5/5, and there is decreased sensory recognition on the right side. Which territory, again, we can see we would expect to be involved? And the answer is left PCA, which is most of the people did. And this was the last one.
All right, brilliant. I think obviously,
Salman.
Yes, Victor.
I want to make an observation. In the question about the most frequent fetal variant artery, I have seen so many posterior communicating artery in fetal variation. And in the brains that I have studied, almost 80 brains injected by myself, I have seen only one trigeminal persistence. Most of the residents put the trigeminal, and for me it's very rare to see trigeminal fetal variation. For me, it's more common posterior communicating artery in fetal variant.
Okay, all right, good. What about you, Ramiz? Have you seen lots of trigeminal persistent?
Not many, but for this particular question, out of the choice out of the others, that was more common than the.
Yeah, I think so. So out of those, I think this was more common. You're right. Okay, I think it was brilliant. We enjoyed that. I think both the speakers are brilliant speakers. I think we really enjoyed it. Rocky and Nikolay did a great job as always. I'm grateful and looking forward to having you again, all four of you. Victor, obviously you're on for your second session, and I'm sure we'll be able to drag Ramiz into it as well at the same time when we are doing that. So it's wonderful to have you, and wonderful to really support our webinars, and I'm grateful, and we'll continue to bother you guys. Don't worry. Okay, pleasure having you all. Have a safe night. Bye-bye.
Thank you so much. Good day. Good morning.
Good
Bye, everybody. Bye.
Bye.
Nikolay turned up. I'm sorry. It's for the webinars for this is for Sunday, and we have WFNS Spine Committee. I'm sorry. Can you show that again, please? I apologize. Can you show that again, please? So WFNS Spine Committee, Juti is going to be talking about management of cervical facet dislocation. Ahmed Zaledi is going to discuss cases. I'm moderating that session for them. And this is Sunday, and it's Sunday evening, same time. This we have already done. Where's the Monday one?
Thank you.
Vlad and Azam. And we have Vlad talking about aneurysmal dissection techniques. And Azam from Wisconsin is going to be talking about endovascular or vascular surgery for neurosurgeon. So he's going to persuade us to do endovascular ourselves and vascular ourselves as well. So let's see what they feel about it. So looking forward to having a great talks again. Thank you, guys. I'm sorry to keep you hanging around for such a long time.
Thank you. Great
you.
Presentation, Dr. Ramesh Kirolos. Nice presentation, nice pictures, and also the combination of surgical procedures and anatomy.
I was relying
Congrats.
on. Thank you.
All the best, guys.
Bye-bye.
Guys.
Nikolai, bye-bye.
Bye.
Bye.
Bye, Victor. Pleasure being with you.
A pleasure. Thank you.